So imagine you have a completely harmless mole, like totally benign.
Right.
Now imagine the skin right around that mole becomes so chronically inflamed that the actual physical pressure forces the mole to mutate its shape.
It literally forces it to disguise itself as a deadly cancer.
Exactly. And this disguise is so good that it fools expert pathologists like over a third of the time.
Which is just a terrifying statistic, honestly.
It really is. So, welcome to the diagnostic nightmare of vulvar nevi. Today, we are taking a massive stack of medical journals, dermatology congress presentations, and clinicopathologic research to answer a highly specific but incredibly high-stakes medical mystery for you.
Yeah, this is a deep dive into what is arguably one of the most complex and deceptive clinical overlaps in modern medicine.
For sure, because the mission for today's deep dive is this. How do dermatologists safely monitor and evaluate structural or pigmentary changes in vulvar melanocytic nevi, which, by the way, are essentially just moles when they are located within an active lichen sclerosus plaque?
Right, and my role today is to kind of guide you through this microscopic hall of mirrors that clinicians have to navigate every day. We are going to figure out how they actually manage to separate a completely benign mole one that's just caught in the crossfire of severe scar tissue from an actually deadly melanoma.
Without putting the patient through, unnecessary life-altering surgery.
Exactly. The environment we are looking at is so hostile, it literally tricks the naked eye, it tricks the magnifying glass, and it even tricks the microscope.
Okay, let's unpack this. We have to start with how these things look to the naked eye before we even think about bringing out the microscopes. We've all heard the basic rules for checking a mole, right?
The ABCDEs, yeah.
Yeah, the ABCDEs of melanoma. So normally, if a mole is highly asymmetrical, has those weird jagged borders, multiple colors.
Lots of color variability.
Yeah, or if its diameter is like suddenly growing larger than a pencil eraser, or it's evolving. Those are massive red flags. We are universally taught that if a mole starts breaking those rules, alarms should go off.
Right, but what's fascinating here is that standard vulvar nevis natively tend to break some of those rules anyway.
Wait, really? Just by default?
Yeah, simply based on their location on the body.
Yeah.
Moles in the genital area naturally exhibit some pretty unusual visual features. They could be quite asymmetrical right from the start.
Mm-hmm.
And they often change color over a person's lifetime, shifting from, say, a dark brown to a grayish hue.
I mean, I found that detail so surprising in the sources. The data is incredibly clear that there is no evidence suggesting melanocytic nevi of the genital skin have any greater risk of turning into cancer than a standard mole on your arm or, your back.
Exactly. They just look a little more chaotic by default.
Right.
And that is the baseline reality for about 1 in 10 women who will develop a pigmented vulvar lesion in their lifetime. But then, then we introduce the crucial variable.
The LS factor.
Yes, lichen sclerosus.
Which is just the ultimate game changer here.
Completely. Lichen sclerosus is a chronic disease that triggers this intense, persistent inflammation. And over time, that relentless inflammation leads to severe thinning of the top layer of skin.
The epidermis, right?
Right, epidermal atrophy. And simultaneously, it causes profound, dense, scarring sclerosis in the dermal tissue beneath it.
Oh, wow.
So you have this incredibly delicate, paper-thin surface stretched tightly over a thick, rigid bed of scar tissue.
So if a normal mole is a photograph, is lichen sclerosus essentially a warped picture frame that aggressively stretches, pulls, and distorts the image trapped inside it?
That is a perfect way to visualize the mechanics of what is happening. The environment is just actively hostile.
It's attacking the mole.
Essentially, yes. The inflammation of lichen sclerosus physically and chemically induces cytological atypia in the melanocytes.
And those are the pigment-producing cells that actually make up the mole, right?
Exactly. The chronic stress of this disease can cause the lesion to rapidly change its surface area, to elevate, or to become thick and nodular.
Oh, geez.
It might even become extremely scaly or start itching intensely as the tissue degrades.
And if we think back to those ABCDE rules we just talked about, an evolving, changing, elevating, itchy mole is a blaring siren for melanoma.
A textbook presentation of a malignant threat. Yet in the context of this warped picture frame of lichen sclerosus, these dramatic, terrifying visual changes are usually entirely benign.
That is wild.
It is simply the mole reacting to the collateral damage of the chronic inflammation surrounding it.
So the naked eye is basically useless here. I mean, the clinical morphology, just the way it looks when you stare at it in the exam room, is actively deceiving the doctor.
Actively deceiving them, yes.
Which means we have to zoom in. We have to transition to the next level of evaluation, which is dermoscopy.
Right, so dermoscopy involves using a specialized handheld instrument. It provides high magnification and polarized light, which lets clinicians see the structures and vascular patterns just below the skin surface that the naked eye completely misses.
It bypasses the surface square,
Yes.
basically. And when you look at a normal mole with a dermatoscope, the architecture usually makes sense, right? Like the research talks about seeing regular pigment networks or organized patterns that look almost like cobblestone streets.
Yeah, you might see fading pink backgrounds or what they call moth-eaten borders. But the overall structure is organized and reassuring.
But how does the LS scar tissue actually destroy that visual pattern? What happens to that nice cobblestone street when you point the dermatoscope at a mole that's trapped in an LS plaque?
Total architectural chaos.
Really?
Yeah. The thick scarring of the lichen sclerosus fundamentally alters how light travels through the tissue, and it physically chokes off normal blood flow. So the dermoscopy of an LS plaque shows a massively decreased total vascular density.
Because the scar tissue is literally squeezing the blood vessels shut.
Precisely. Instead of a healthy pink background, you are looking at stark, whitish, sclerotic plaques, and the blood vessels that do survive, they become wildly polymorphic.
Meaning they're just all different random shapes?
Right. You see chaotic linear vessels, dotted ones, and these tightly wound hairpin-looped vessels, trying desperately to supply blood through the scar tissue.
Though it is worth noting a detail I found in the clinical presentations because the research specifically highlights that you do not see spermatozoa-like vessels.
Oh, yes.
I actually had to look that up, but those are basically tiny blood vessels shaped like little tadpoles or, sperm. Why does their absence matter so much in all this chaos?
That is a crucial distinction. Those specific, distinctively shaped spermatozoa-like vessels are a classic hallmark of true invasive melanoma.
Oh, I see.
Yeah, their presence strongly suggests a tumor is building its own aggressive, disorganized blood supply. So when a doctor is looking at all this chaotic scar tissue and they realize those specific vessels are absent, it is actually a massive sigh of relief.
It's a point against malignancy. Okay, that makes sense. But still, the overall visual is a mess of overlapping patterns.
Yeah.
And these patterns heavily mimic other completely different conditions. The sources mention it can look like basal cell carcinoma, seborrheic keratosis, or angiokeratomas.
It's a very crowded diagnostic picture.
So I kind of have to push back on the utility of dermoscopy here. If the LS plaque creates this whitish sclerotic background, I think one of the sources called it a white glow or a cloudy sky of scar tissue, doesn't that just obscure the mole even more?
It does.
It sounds like trying to study a star through a thick layer of fog. How does this expensive magnifying glass actually help the patient in this situation?
That is a highly perceptive critique. You are absolutely right that dermoscopy has severe limitations in this specific scenario because it is exactly like looking through fog.
Right.
What the tool can do, however, is help clear away some of the other suspects in the diagnostic lineup.
Okay, how so?
For example, it can confidently differentiate the white glow of vitiligo or the fibrotic beams seen in a condition called morphea from the specific dense scar patterns of lichen sclerosus.
Ah, got it. So it proves that the warped picture frame is definitely LS, but it doesn't tell you if the picture inside is safe.
Because when the clinician looks at the mole itself through that fog, the dermatoscope often reveals what the literature calls suspicious criteria.
Like what?
You might see an atypical, thick black network, irregular radial structures, or these chaotic pigment globules.
So the magnifying glass essentially just confirms that the mole looks incredibly suspicious, leaving us right back where we started.
Unfortunately, yes. Because dermoscopy alone cannot safely rule out melanoma in this unique, cloudy environment, the clinician's hands are tied. They cannot rely on visual inspection, magnified or otherwise, without risking a misdiagnosis.
So they have to cut into it.
Exactly. The next logical and absolutely necessary step is a biopsy.
Moving from the magnifying glass to the microscope, we're taking an actual sample of the tissue and looking at the behavior of the individual cells.
Right.
Which brings us to what I think is the most mind-bending part of this entire deep dive. The microscopic hall of mirrors.
Here is where the cells themselves are actively wearing disguises.
Here's where it gets really interesting to me. I want to bring up that statistic from the hook because seeing it in the research genuinely stopped me in my tracks.
The Clark et al. Study.
Yes, the study by Clark et al. That looked at 56 cases of atypical genital nevi sent out for expert consultation. Out of those 56 cases, 20 had been previously misdiagnosed as a melanoma,
Staggering.
over a third. And we aren't talking about, a general practitioner glancing at a mole in a dimly lit room. We are talking about highly trained tissue pathologists looking at cellular structures under a high-powered microscope and getting completely fooled.
Right, and if we connect this to the bigger picture of tissue pathology, you start to understand why those experts were fooled.
Please make it make sense.
It all comes down to the way lichen sclerosus physically forces the mole to grow. The sources describe these as pseudomelanomatous features, literally false melanoma features.
Okay.
And the most prominent of these is a trizonal pattern that is incredibly unique to Nevin-Cotton LS.
So talk to me about this trizonal pattern. The sources describe it almost like an archaeological dig with 3 very distinct layers.
It is a masterclass in biological mimicry. At the very top, in the epidermis, you have a cellular pattern that perfectly mimics melanoma in situ, which just means a superficial localized cancer.
Okay, that's layer 1.
Below that, the middle zone is a thick, rigid band of dermal fibrosis. That's the scar tissue generated by the lichen sclerosus.
Right.
And then, trapped deep underneath all of that dense scarring is the third zone, the remnants of a perfectly normal, benign dermal mole.
It's like a benign mole got buried alive by the scar tissue, and the cells trapped at the very top are just absolutely panicking.
That's a great way to look at it.
And the descriptions of these top cells are terrifying. The sources talk about confluent junctional nests, meaning the cells are clumping together in these abnormal heavy clusters.
Yes.
And they show pagetoid spread. I kept seeing that term. How does pagetoid spread work?
So normally, melanocytes are very well behaved. They stay neatly lined up at the base of the epidermis, right at the junction where the upper skin meets the deeper dermis.
Like good little soldiers.
Exactly. Pagetoid spread means these melanocytes are breaking the rules and migrating upward, infiltrating the upper layers of the skin toward the surface.
And why is that bad?
Because biologically, that upward migration is one of the ultimate hallmark features of an invasive malignant process.
Oh, wow. And it doesn't stop there, right? The cells even look atypical.
Yes, they do.
They are slightly larger than normal mole cells, with abundant, pale to dusty gray cytoplasm and prominent nucleoli. I mean, if these cells are literally doing a perfect impression of melanoma, they are sneaking upward, they're growing abnormally large, they are grouping in bizarre nests. How is a pathologist supposed to sleep at night? Are they just guessing when they write the final pathology report?
I know it sounds like a coin toss, but they are not guessing. What the pathologist has to recognize is the mechanism behind this terrifying cellular behavior.
Right.
The cellular atypia isn't driven by a malignant genetic mutation inside the cell. It is a mechanical and chemical reaction to the trauma of the surrounding environment.
So the cells are literally being squeezed and stressed by the scar tissue into looking evil.
Exactly. And we also have to account for the epidermal consumption illusion.
What's that?
Because the top layer of skin, the epidermis, is battered and paper-thin from the lichen sclerosus disease. It creates a severe visual trick under the microscope. It looks as though the mole's melanocytes are aggressively eating away at the epidermis, which is exactly what a cancer would do.
Oh, I see.
But in reality, the skin is just naturally wasting away from the inflammation, and the mole cells are just sitting there in the ruins. It's an optical illusion.
Wow. Okay, so we've established that the naked eye is fooled by the ABCDEs, the dermatoscope is fooled by the foggy scar tissue, and the standard microscope is being actively deceived by the trizonal pattern, the pagetoid spread, and this epidermal consumption illusion.
It's a minefield.
So what does this all mean for the patient sitting in the exam room waiting for a diagnosis? How do doctors actually break the illusion and find the truth?
This is where we rely on the definitive tools of modern pathology, combined with, surprisingly, one of the oldest clinical tools we have. Let's start with the microscopic lie detectors.
Okay.
Even though the mole is wearing a very convincing melanoma costume, it still gets a few subtle details wrong.
The histological keys.
Right. True melanoma behaves very differently in the deep tissue compared to a stressed benign mole. A key differentiator is a biological process called dermal maturation.
How does that work?
In a benign mole, even one panicked by scar tissue, as the melanocyte cells go deeper into the tissue, they naturally mature. They get smaller, they disperse, and they begin to look more like delicate nerve cells.
And melanoma doesn't do that.
Exactly. Melanoma lacks dermal maturation entirely. Cancer cells stay large, aggressive, and abnormal all the way down.
Got it. The research also notes that true melanoma cells have deep mitotic figures, meaning they are actively, aggressively dividing deep in the tissue, which normal mature cells don't do.
Correct.
And you see cellular necrosis, actual dead zones within the tumor where it's growing faster than its own blood supply.
Furthermore, in our trizonal pattern, the benign mole is physically sandwiched and contained by the scar tissue. Melanoma does not respect boundaries.
It just pushes through.
Yes. Its poorly circumscribed cells will aggressively extend laterally and vertically, pushing entirely past the dermal changes of the fibrotic scarring.
And when looking at the physical structure just isn't enough to be absolutely certain, they bring in the chemicals, right? The histochemical stains.
Yes, the definitive tiebreakers.
Instead of just listing the alphabet soup of markers from the sources, let's talk about how they actually work. Pathologists use specific immunohistochemical stains, things like HMB45, S100, Milan A, or MART1, which essentially act as targeted molecular tags.
Exactly. By washing the tissue sample in these chemical stains, the pathologist can force the cells to reveal their true metabolic nature.
Oh, that's cool.
The stains only stick to very specific proteins. For instance, strong, deep tissue expression of the HMB45 protein is a massive indicator of melanoma. Yet the stain doesn't stick to the deep cells. It strips away the visual illusion and proves the cells are benign.
Okay, so that is the incredibly high-tech molecular way to break the illusion. But you mentioned one of the oldest clinical tools, too. And the sources are very clear on this for the clinicians. Doctors cannot just rely on their eyes. Even before the biopsy, they must palpate the area.
The power of human touch.
Right.
This is a critical point for any clinician to remember, and honestly, for any patient advocating for their own care. Visual inspection is never enough in a diseased environment.
Because a classic presentation of actual cancer in this environment, or even a severe precancer like differentiated vulvar intraepithelial neoplasia, which essentially means the surface cells are growing wildly out of control, involves something you can physically feel.
Yes.
The doctors are feeling for firm, hard, indurated nodules beneath the skin. And the patient experience is vastly different, too. We're talking about excruciating pain.
Right. One of the clinical experts in the sources noted cases where patients with true malignancies couldn't even sit down because the pain from the firm nodule was so incredibly severe.
That's awful.
If a clinician feels a firm, hard nodule accompanied by intense, localized pain, that tactile reality supersedes any visual ambiguity from the dermatoscope. That demands immediate biopsy to rule out malignancy.
Which brings us to how these biopsies should actually be performed on the patient. Because the sources heavily emphasize biopsy best practices for these pigmented lesions. You don't just shave a little bit off the top with a scalpel. Excisional biopsy is preferred.
Definitely. And it goes right back to that deceptive trizonal pattern we just discussed.
Right.
If a doctor only takes a shallow surface shave biopsy, they might only capture that top epidermal layer.
The panic layer.
Yes, the layer that perfectly mimics melanoma in situ. And they will completely miss the reassuring benign mole trapped underneath the scar tissue.
Which leads directly to a false melanoma diagnosis.
Exactly. You have to get the full architecture of the lesion, reaching all the way into the subcutaneous tissue to make a safe, accurate diagnosis.
And I really have to highlight a practical, empathetic detail included in the sources about patient comfort during this procedure. Getting a full-thickness excisional biopsy in a highly inflamed, extremely sensitive area sounds absolutely agonizing for the patient.
It can be.
But there's a specific pain management trick mentioned. Applying a topical lidocaine cream and covering it with a piece of saran wrap.
It's quite clever. The saran wrap acts as an occlusion dressing. It traps the heat and moisture, which forces the topical numbing cream to absorb deeply into the damaged skin barrier.
Okay.
Once the surface is entirely numb, the doctor then injects the deeper lidocaine mixed with epinephrine. The epinephrine constricts the local blood vessels, keeping the numbing agent exactly where it's needed and significantly reducing bleeding.
It's a simple, elegant solution that makes a daunting, painful procedure tolerable. It ensures the clinician can actually take their time and get an adequate full-thickness sample without traumatizing a patient who is already dealing with a painful chronic condition. It's just so ironic to me, though. We spend all this time talking about polarized light dermoscopy, pagetoid cellular spread, and HMB45 molecular stains, and yet one of the most vital diagnostic tools in this entire process is just a doctor pressing a finger against the skin to feel for firmness and using a piece of saran wrap to make the patient comfortable enough to get a good sample.
Medicine is always a delicate balance of the microscopic and the macroscopic, and this raises an important question that we need to clarify to ground this whole discussion. With all this talk of cancer and perfect melanoma mimics, how common is the nightmare scenario?
The actual coexistence of lichen sclerosus and vulvar malignant melanoma occurred at the exact same time in the exact same spot.
It is exceptionally rare.
Good.
Single cases have been described in the medical literature, but they are unicorns. The vast majority of these terrifying-looking, aggressively changing black and blue lesions within an LS plaque are perfectly benign nevi.
They are just innocent bystanders caught in a dermatological war zone.
Exactly. The inflammation severely distorts their shape and behavior, but it does not fundamentally corrupt their genetics. They are benign.
That's a relief.
It perfectly illustrates why specialized pathologic knowledge is so crucial. Without understanding the context of the lichen sclerosus, it is dangerously easy to overdiagnose melanoma and subject a patient to unnecessary, life-altering surgery and psychological trauma.
Which is exactly why that Clark et al. Study exists, to warn pathologists to look deeper and trust the deep tissue maturation when they see this specific combination of scars and moles.
Absolutely.
Let's bring this all together. We started with a medical mystery. How do you safely monitor a mole when it's hidden inside a disease that turns it into a perfect cancer mimic?
Right.
We journeyed from the initial panic of the ABCDEs failing us through the foggy, cloudy sky lens of dermoscopy. We navigated past the microscopic illusions of the trizonal pattern and epidermal consumption, where benign cells are literally squeezed into a melanoma costume.
Very convincing costume.
Very. And finally, we found safety in the molecular truth of histochemical stains and the undeniable reality of a careful, tactile clinical exam.
And it leaves us with a lingering concept, something I want you to mull over after we finish today. We usually think of cancer as a rogue cell that just decides to mutate on its own, right? A spontaneous genetic error that spirals out of control.
Yeah, that's the standard narrative.
But this phenomenon with lichen sclerosus shows us something profoundly different about human biology.
It shows us the sheer power of the environment.
Exactly. It shows us how a highly inflamed, fibrotic environment, the literal neighborhood the cell lives in, can physically and chemically pressure a completely normal, healthy melanocyte into mutating its shape and behavior to mimic a deadly disease. The warped picture frame doesn't just stretch the picture, it forces the ink to run.
Which begs a fascinating question for the rest of human physiology. What other benign cells in our bodies are currently wearing the mask of a deadly disease, appearing malignant under a microscope, simply because they are caught in the crossfire of chronic inflammation?